Yeah. Usually a bag or something, just so that they know exactly what you brought in case
Right,
it gets something.
exactly. But
Yeah.
to tell somebody not to bring in anything, not to bring their phone in, I said, well, it's not that I live on my phone, but there are a couple of people I might want to call, when I come out of the anesthetic. That might help. They might be happy to hear from me.
Yeah.
Anyway, I'm sure it'll be fine. I'm hoping I'll be out of there by early Thursday morning.
What are you doing, Rick?
What am I doing? I'm getting a new hip.
Oh, really? Oh, wow.
Yeah. I'm
Okay.
going to be doing the
Good
CanCan
luck,
on Saturday.
Rick. How many hips has this doctor done?
Oh, a lot. I can't. I figured it out, but he's done a lot. He does
Okay.
about
That's
60 a year, or 80 or 100 a year, somewhere between 60 and 100 a year, and he's been doing it a long time.
okay.
I'd have to
Right
look
hip,
at my notes
right hip,
to tell you.
right hip or left hip?
Um, I'm doing well. That's a good question, because I'm going to say to him to make sure he knows it's the right hip, the left hip. Because if he does the right hip and he should have done the left hip, and I want to sue him, I won't have a leg to stand on, right? I know. It's gonna be terrible. But Paul, this doctor's really cool. He's really cool. Some call him a hip doctor.
Is that supposed to be British humor?
Yeah, thick British, black
I
British
think
humor.
I think Rick has started taking the anesthesia ahead of time.
That's right. That's absolutely right. Well, I had a little accident on Saturday. That's what I was just telling my buddy about it. Who was my friends were visiting me were visiting, not me. They were in Tucson for 3 weeks from St. Louis, and they actually left Saturday morning. So I'd seen them a few times, and I was just telling my friend David. So I went out on my mountain bike. I mean, the thing with this hip is that biking has been fine, cycling has been fine, and using the rowing machine has been fine. But the only thing I really cannot do, as Dennis Correa will attest, is walking has been a bit of a problem. I mean, even when I saw Peter, it was. So I've been gimping around for a long time. And they told me 2 years ago that I was bone on bone. So I've just been putting it off and putting it off. But it got to a point where really it's not that comfortable to be walking most of the time. So I go out on my mountain bike because I'm still exercising every day. So I go out on my mountain bike on Saturday, and I'm riding on some single track, and I'm going up a hill, and I kind of lose my balance, but I don't really fall. I sort of totter, and I think, oh, I'm not going to fall, and I don't unclip in time, and I topple, and I fall on my left side, which is where my bad hip is, which is what I usually do. And I'm lying on the ground, and I look underneath my left arm, and I see there's blood underneath the top of my left arm, like underneath my left armpit. I'm thinking to myself, wait a minute, what did I do? Catch myself on a rock or something? And then it just wipes away. And what happened is that I must have caught my leg, um, the inside of my right leg, on the chain ring, on the big cog of the chain ring, and and it made a slice that was about 2 inches long, and it nicked an artery, and the arteries were all compromised in the bottom of my leg because I had a procedure when I was about 4 months old, so the it's all of the veins and arteries are near the surface in that leg. So I think to myself, it's like when you watch those war movies and stuff. Oh, I better apply pressure. So I applied pressure. And I was on my own, and I had a bandana. So I pull out my bandana like with one hand, and I'm trying to keep pressure with one hand and tie up the bandana. So I tie it as tight as I possibly can, and tie it off. In the meantime, there's like blood everywhere. The bandana quickly gets soaked, the sock gets soaked, the shoe gets soaked, and I start heading home. Well, by the time I get home, and I don't have any pain, but I think I had a little bit of shock because I was sort of feeling it a little bit on the way home, and I had to go up and down a few hills to get home because I was kind of quite a long way out. So I get home and I just walk into the bathroom. I put one foot in the bathtub and I've got a bucket and I start taking stuff off, and it was like a Hitchcock movie. I'm not kidding. I mean, I must have lost. I honestly think I probably lost half a pint of blood. I mean, it was everywhere. And then I start cleaning it up, and it's fortunately a very clean, like 2-inch long incision, and it starts spurting again. It starts spurting again. And then I gotta stop it anyway. I was worried that they wouldn't do the surgery tomorrow, but it doesn't seem like I have an infection, and so and I didn't want to get it all stitched up because I didn't want to get any. I didn't want to risk it getting any worse than it already was. I figured if I could stop the bleeding, it would be fine. And so that's my story. I'm sticking to it. And as far as I know, I got to be at Northwest Hospital at 10:30 tomorrow morning, and I can't wait to get it out of the way. So there you go.
And they're only keeping you overnight, huh?
Well, that's an interesting story, Jake. He would have done it outpatient, but my insurance would have required a copay of $2,800 for outpatient, whereas if I stayed in overnight and went inpatient, the copay is $180.
Okay.
So
Thanks.
it doesn't.
I'm just surprised they're keeping you that short of a time period, because I think my brother, he had a hip replaced several years ago. I don't know how many years ago now. He's dead, but I thought he was in the hospital for like 3 days or maybe longer. I might be wrong. So yeah, that's great.
Don't tell me he's dead. I hope it didn't have anything to do with that hip replacement.
No, he is dead, but it had nothing to do with his hip.
Oh, thank goodness. Okay. All right. I feel better already, Jake.
Yeah.
You know how to make a man feel good. I have a brother. He had a hip replacement. He's dead.
He's dead now.
Yeah. No, I mean, my buddy Dave Fisher had it done, and he was out the next day. And
Okay.
they really try and get you out quickly right now. And like I say, I would have done it outpatient, but I just, I wasn't going to put an extra couple of grand in the
No,
pocket.
no, that's ridiculous. I mean, it makes no sense, actually. It's typical bureaucracy, makes no sense.
Well, somebody said to me that the reason is because they can't bill as much for outpatient, so they make it more expensive so that the insurance companies and the hospital gets just as much money out of it, or whatever it is.
Yeah.
I know. I mean, it's kind of crazy, and there is a way to do it because they can actually keep you in for observation as an inpatient and then let you go, but because Dr. Steve told me that. But it's too complicated to try and get them to do something they've never done before. And then people say,
Right.
you know what, you're better off staying in overnight. And they're probably right because I wouldn't have anybody here in the house overnight. So I'm probably better off.
That does make sense. Are you going to have physical therapy then after that?
Yeah.
Okay.
Yeah. Yeah, but I've been trying to buy a skull, a rowing skull, since October. I found it. They were supposed to ship it out in December, and they made a boo-boo, and then they shipped it out, and then they finally decided to ship it out on January the 4th. And I told them twice, whatever you do, I cannot receive the boat on January the 10th. What do you think? They called me today. Oh, the boat will be there for you tomorrow. I said, no, it won't. I'm not going to be here tomorrow. So I've been having to figure that one out and get it changed, but it's not a big deal.
Well, anyway, good luck to you.
Thanks very much. Yeah, I'm sure hopefully I'll be alive and kicking for next Monday's meeting.
Oh, I'm sure you will be.
More kicking than alive is what I'm hoping. Okay, so let's see who we've got on this call. We have Peter, Dennis, Jay Krukman, Paul Frieda, Jake Hannum, Len Sierra. Did I miss anybody? No. Okay. All right. Small crew to kick off with here. I started putting this group back on Inspire. I haven't done that for a long time, but given that we're sort of constantly now around the 10 to 15 number every time, I figure that we can open it up. I mean, it's always open. Anybody can call any time, but I just haven't advertised it because I was worried about overload. But at least for the time being, we'll see if we get any new folks and where we go. All right, so let me run down the list. Peter, what have we got to discuss with you today on anything? We have plenty of time.
Okay, well, put me in. I just did a blood test a couple of hours ago. I won't have the result until tomorrow, so
Okay.
that's got me a little bit on pins and needles. But I'm kind of expecting what the result's going to be.
Okay. We got you in. Dennis, how was your holidays? Because I haven't talked to you. And is there anything you'd like to discuss?
Number one, the holiday was good. And our daughter was visiting from Memphis, and
Great.
I had a good week with her, and completely forgot about the call last Monday. That's why it wasn't on.
No problem.
But nothing significant, no changes for me.
Okay. Dennis, I keep thinking about you because I discovered where the back 9 of the 2 back golf courses, and I can cycle over there, and there's another bridge over the river there, so I can use it. So I'm cycling all around that back 9 now. It's very nice.
Yeah, it is. Yep.
So talking about Memphis and Nashville, Jay Krukman, how are you?
Happy New Year to everybody.
Happy New Year.
Yeah, I'm good. I do have an update from some lab results and a visit to the doctor the other day.
I'm putting you in. Got you in. Paul Frieda in Florida. Are you there, Paul? You were there a minute ago.
Yeah, I'm here. I had you muted. I don't have anything right now. No. Thank you.
Okay. And since we're in Florida, let's go to our other temporary Floridian. How are you, temporary Floridian? Did you arrive?
Would that be me?
It would be you. Yes, Len?
Yes, certainly I've arrived. I've been here almost a week, and it's nice and warm today, mid-70s, sunshine, beautiful day.
Good.
I could talk a little bit about the clinical trial working group if seems like we'll probably have time.
Yes, I'd love you to. I'd love you to.
By the way, is anyone sharing their webcam? I don't see anything.
Oh, I forgot. Thank you, Len. I forgot. I will be momentarily. There you go. Sorry.
And I'll do mine too.
My mistake.
Speaking of sharing, Len decided to show off on Facebook with a picture of him standing in front of the beach, saying, "This isn't snow, this is sand," trying to rub it into all of us who are in the cold, nasty.
Yeah, that's not nice. You know.
Thanks a lot.
Yeah, hey, big.
The white,
I could do that.
crystal white sands of Siesta Key.
I could do that, big stuff, but I don't do it, because I'm a nice guy. I don't want to make me spill. What's the temperature there, did you say?
I think it was mid-70s.
Okay.
I was walking around in a t-shirt and shorts, so I'm thinking probably mid-70s, although I didn't even check.
Oh, well, we're finally, and
And you
everybody,
said you're cooling off now.
well, everybody's very excited because we should get some of this California rain tomorrow. So people get, as Dennis will tell you, people get quite excited when it rains here. They look forward to it. And I just took my bike out. We're right around 70. So is that right, Dennis? What do you got in Tucson?
I think it's probably about 74 or so.
Yeah, there you go. So but Dennis, we don't flaunt pictures of ourselves half naked, do we? And we don't do stuff like that, do we?
No, no, you don't want to make people feel bad.
That's right.
Hey, I don't mind. That's their problem.
I feel sorry for my poor friends who left on Saturday because they'd been here through this really cold spell, and all of their friends back in St. Louis and St. Charles were giving them grief, and then they've got to go back to it. Jake, anything for you?
No, I don't, Rick.
No. Okay.
No, I feel like crap today. I think I might be coming down with the flu,
Oh,
Ooh.
no.
and I may be dropping off early. But
Oh, your
no,
wife?
Huh?
Your wife was sick recently, right?
Yeah, she was sick over Christmas, on Christmas Day, believe it or not. We had to cancel our dinner. Yeah,
So did you have
I don't know.
Did you have your dinner instead?
Yeah, but it ended up being 3 phases instead of just one. My one son came over, had dinner, then my other son came over, had dinner, and then her brother and mother and her brother's family came over a third time. So it did not work out simply, that's for sure.
Was this 3 dinners all on the same day, or?
No. It was my one son decided to risk it and come over Christmas night.
Yeah.
My other son came over Wednesday night, and then her brother and her mother came over on Saturday night.
Yeah.
All so she ended up making 3 dinners instead of just one.
Oh man.
Yeah.
So,
It's all good.
sorry to. Anyway, well, be careful because this flu that I've known a couple of people get is kind of vicious because it gives you a nasty cough and you feel rotten and then you can't get rid of the cough. And I mean, if it's the same thing, I've seen 2 or 3 people with that. Did you get a flu shot?
Yeah, I did. Back in October, but I've been reading that flu shot is not very effective this year. It apparently is only like 10% effective or something like that.
Right.
So hey, Eric's joined us.
I know. I was waiting to say hello to him. Hey, Eric. Gosh, you look so much better. You're not you don't look so bloated from the steroids.
And no black
Right.
eyes.
Yeah, no black eyes. They changed my steroids. I'm taking hydrocortisone instead of Decadron.
All right. Well, we're not even asking you. We're telling you. We're putting you in for an update. Okay? Happy New Year, buddy.
All right.
Happy New Year.
Good to see you.
All right. So let's kick off with Peter, and then we'll go from there. I do have actually. Let me just take care of this up front. I do have some sad news that Ron Silverio passed away 2 or 3 days ago. Now, you may remember, I mean, Ron was on the call pretty often, and his wife, he was always on with Susan LaHaye, his wife. Susan's a retired Air Force lieutenant colonel. She was a nurse in the Air Force, and she's really quite an incredible woman. And I met Ron through Jerry because Susan's cousin in Emeryville was a really good friend of Jerry's, and so that's how I came to find her. And we've been supporting Ron for 4 years now, 3-4 years. I don't know if any of you have noticed, but it's linked on the In Memoriam page. It's also linked on the in the news and events page, and I'll try and put it on here in a minute. But Ron and Susan became advocates, strong advocates for death with dignity, end of life decision making, and last year Susan appeared in the Delaware State House to lobby for the representatives to pass the bill, and Compassion and Choices worked with Ron, and he made a really moving short 2-minute video, which is what I posted, and then last week, right at the beginning of last week, he had an editorial in one of the main Delaware newspapers, and he passed away a couple of days later. So, I mean, this was no surprise, and I thank God that he was able to hold on through Christmas, because both his boys were able to be there, and that was really important. He was a pretty incredible guy, and when you see this video, you'll see how strong he was, and Susan equally so. And we've been supporting Susan regularly on the Caregivers call as well. So I just want to remember him, and for the fine man, as his cousin said, who was a friend of Jerry's, that she's sure that these two big-hearted Italians are hugging each other right now. She's probably right. So anyway, I just wanted to say that. So Peter, go ahead.
Rick, did he have a physician-assisted death?
He did not, because it wasn't legal. It's not legal yet. They're voting on it, I think, this week. I have to find out from Susan. But the answer is no.
What state?
Delaware. So let me. But I will, as Peter's talking, I'll post the. I'll put the post in the window. So I don't know. I have not heard from Jim Cameron. I sent him an email. I did plan to call today, but time got away from me before the meeting started, and so I haven't done that. But I will try and call and find out what's going on with him. So he's just he's in your rough area, isn't he, Len?
Yeah, I did send them an email about a week ago, and I didn't get any response. I don't know if I should call or not.
Yeah, I didn't either.
I guess I could try.
Yeah, I did not either, and that bothers me. So, well, maybe we'll both try, but I don't know. I just don't know. Okay.
Is Oregon, as far as I know, is the only state that has a death with dignity?
California does. Oregon does.
Okay.
I think Washington. There are a lot of states that have.
Okay.
I don't remember, but if you go to Compassion and Choices, then I think you'll find a list on there. Let me just. I'll put that website in. So keep talking, and Len, you keep doing what you got to do until I get this stuff posted, please. Okay. But Peter, you're up.
Keep doing what I.
Well, in place of me, so I can look.
Oh, I'll get you. Sure. Yeah. Go ahead.
We're advertising you as the co-moderator, so step up.
That's right. Thank you, Jay. Thanks for
I step up. I just fell down. I thought you were talking about Jim Cameron.
No. Go ahead, Peter.
Okay, well,
Okay, then, since I'm in command now, Peter, you're on.
okay, I've got kind of a hodgepodge of stuff here. So I did my monthly blood test this morning. I won't have the result until tomorrow, which is good. I mean, I've got a lab that's really on top of things. They process it right. They process your PSA and your testosterone right away, and send you a note that sorry, the phone is going off here.
Not guilty.
Huh?
Not guilty.
No. Anyway, they
No, it's Peter.
yeah, no, it's my phone. Yeah, they send you a notice right away, and I usually have the results by tomorrow morning. So, which is pretty fast. You know, when I see some people, I mean, there are some labs that won't give you the results and make you go through your doctor, or, you know, make you wait a week and go through all kinds of, you know, crazy anxiety stuff. But my lab's pretty good with that. So I'll know more tomorrow. But as most of you know, my you know, the signs of recurrent. Even though my PSA is very low because I don't have a prostate anymore, it's down in the. My last reading was at 0.3, but it's been jumping. It's been doubling every 2 months at this point. So I should know more tomorrow, and then I'm going to make a game plan. At this point, I've got a place reserved, a hotel reserved in San Francisco, the end of February, beginning of March, and my plan is perhaps to take an Axeman scan the end of February up in Berkeley or Walnut Creek or something, and then jump down to LA and see my Dr. Turner down there in LA, my oncologist, beginning of March, and decide what the plan is. And if I need to get a better scan, I'll do that. If you know, pay out of pocket if I need to do that or whatever. So I'm a little bit nervous, but I think I'm okay. You know, we're catching this early, and we'll see what it is. The plan, as I've said before, is to let the PSA get to 0.5 and then see what the scan shows. And then if I need to go on Zytiga or Xtandi or something like that, I'll look at that. If I can get on immunotherapy, I'll do that. You know, just kind of look at the next steps and see what the strategy is. So that's a quick update on that. There was some discussion. You know, again, I'm going to jump around a little bit, get away from myself a little bit. There was some discussion last Monday. I was going to pipe in, but we ran out of time. And I think I've brought this up before. You know, I think there's some merit sometimes to having your medical oncologist outside of the system where you're getting other treatment. You know, rather than, you know, if you've got a surgeon or you've got radiation people at one facility, you know, rather than keep your oncologist in that facility, I found it's good for my situation to have my oncologist outside of those systems, just to get a different perspective, because they, you know, there are different viewpoints on medications and you know, whether you go on hormone treatment, whether you don't, when you go on it, what kind of treatment you take, and so forth. And, there's a little bit of discrepancy in that. And, so I appreciate having an oncologist who's not wedded, you know, to a system, so he's not going to go against another doctor who's within the same university system or hospital system. So that's my take on that, and that's why I've chosen to keep keep my oncologist down at prostate oncology specialist rather than go with UCSF guys, even though my surgeon was there and my radiation guy was there. If I'm in San Francisco, I'm thinking, you know, if it looks like there's, you know, I don't know where this reoccurrence is, what it's going to look like, you know, or if it is indeed happening. But I was thinking of maybe making an appointment with Dr. Shu up there and just kind of talk story with him in terms of, you know, what the possibilities are in terms of spot radiation and how much more radiation my system can take, because I've already been to IMRT. So, you know, I might make an appointment just to kind of, you know, kind of talk strategy with him, because Dr. Chang has left there, and just see what my options are, even though I don't have a plan yet and have no idea what's going on. So I wouldn't mind hearing what you guys think about such a strategy. You know, whether that's smart or a dumb thing to do at this point, but that's my thinking right now since I'll be up there. Give you a quick update. I've had 3 meetings now here on Maui of my live support group. We meet on the 1st and 3rd Wednesdays of each month, and so far it's all been guys with prostate cancer. It is open to anybody. It is open to people with other cancers and so forth, and I've got a few on my mailing list, my email list and so forth, that I let know that I know that have other colorectal cancers and other ones. But so far it's just been guys with prostate cancer, and which has been great actually. We've had four people at the last couple of meetings, and 2 of us have been through treatments. 2 of them are kind of, you know, sitting there on the proverbial fence trying to figure out what to do with their 4+3s, and trying to make a treatment decision. I'm on the phone with other guys who I've connected with here who I haven't met yet. Who one's going to Dr. Sperling this month to talk with him about FLA. I think I can't remember whether he's got a 4.3 or a 3.4, but anyway. But he's decided to go that way. He doesn't want to come to a meeting as he feels he's been talked out of going to Sperling. And the other one's heading to San Diego to see Dr. Rossi about proton beam therapy. And both these guys are comfortable about paying out of pocket. They know that they're not going to get covered by insurance, but they've thought it through and they've done research, and they feel that's the way they want to go. So anyway, so I spend as I do meetings with these guys. You know, I feel that's just as significant as the live meeting. You know, just keeping in contact with them, keep calling them. You know, I've got a kind of a stable full of guys I keep in touch with and make sure I check in with them every week or so. Just so they know they've got somebody else in their life and who cares about them other than just their family. It's helpful. I know I feel that way when people check in with me. So, and the other thing is, I had a wonderful lunch the other day, a couple of weeks ago, with her name is gone from my head right now. What's her name?
Helen Tomasco.
Yeah, yeah, Helen. And, she's a great family. Oddly enough, she's got a husband with prostate cancer as well as a diabetic condition and some other health issues, and he's a little bit in denial of things. We talked a bit, but it was a good lunch. We met in town, and I think she'll be great with the breast cancer group.
Well, you have to tell people why you had lunch with her.
Oh yeah, she's going to be one of the co-moderators of the women's breast cancer group. She's what is she, triple negative or something like that? But yeah. She's in remission. She's doing fine. This was many years ago that she was diagnosed. So, but she's passionate about helping other women, and she's in her 70s and going to law school now, and wants to be a legal advocate for women, not only with cancer, but with other issues and so forth. So she's a real go-getter. And her children are as well. So her daughter, two daughters. So we had a great time. It was really nice. So it reminds me that, this is Maui, like Florida, is a vacation spot. A lot of people come through here. Rick turned me on to a friend of his a couple of years ago who comes here every year, and I've lost contact with him. But probably a number of people in treatment come through Maui from time to time. And I'm willing to reach out and be a friend if you know of anybody that comes this way. So that's kind of my hodgepodge of things. I'll let you guys know more when I get my results tomorrow.
So there are two things I want to pick up on, Peter. One is I'd like to just open the discussion up a little bit on the doctors, choosing a doctor outside of the regular network. And then what was the other thing that you asked us for your opinion on? I forgot to make a note of it.
Consulting while I'm in San Francisco the end of February, consulting with Dr. Shu about, just what,
right,
without knowing anything, see what he thinks about possibilities, because I don't know how much radiation the body can take without damage. I've already had 70 grays, via MRT, and had PET scan, and I'll be getting an oxygen scan. You can overload, I guess, on this stuff.
I think you can, but I don't. I think that you probably have some space in there. I mean, I know personally, I got 45 grays of IMRT, and I got about 90 grays through the brachytherapy. But I don't think that they're necessarily, you can't just add them together because it's different. When it's given in different ways, you can probably get more. But the one thing I was going to say to you is, Shu is a good option. But Felix Feng is also a very good option if you can get in to see him.
What's his last name?
Feng, F-E-N-G.
Okay.
I mean, he's really now he's the star there, and Mac's good as well. Mac's always good.
Right.
Mac Roach. So
right.
There are other alternatives, and then I forget the name of the guy. There's a new guy there. Because somebody told me they saw him, and I forget his name. I haven't made a note of it, but any of those three. Oh, and Gottschalk is good as well. Gottschalk, Alex Gottschalk. So don't limit yourself to Joe Shu.
Okay.
Let me ask. It's sort of particularly interesting with Jay Krutman on the line because it's an issue that he's facing too. But what do other people feel about getting second opinions from doctors outside of your regular network? I mean, I will share with you that I've been trying to convince Rob Baniskas to do this. Rob, who is amazing, he doesn't participate in these calls for a bunch of reasons, but he does so much for AnCan. It's incredible. And he's not responding to Jevtana, cabazitaxel, and he has a very strange type of disease. He's got significant soft tissue mets, but no bone mets. And his disease has always been that way. And he's young, he's 54. He got 4 years out of Zytiga. And he sees a doc called Stuart Bloom in Minneapolis, who he likes, who's not in the university system. He's part of Minnesota Oncology, but he's a good doc, and he does participate in some research. But I wrote to Rob yesterday and suggested to him that he get a second opinion outside. And he wrote back and he said, well, you know, why would I want to do that? And I said, well, I think it's a good idea to get, especially when you're looking for alternatives, to bring in more views, more people, because you never know what somebody in, particularly in a research and university setting, might have seen that somebody like Stuart Bloom might not. Eric's another one. I mean, Eric's had somebody in a university setting and somebody outside of a university setting for 2 or 3 years now. So it's a discussion. We have time today, and I'd just like to get input from other people for you, Peter. What do they think?
I believe you can never have too much information. So second, third, fourth opinions, sure, why not? As long as they have access to all of your records, I don't see any reason why you wouldn't want to do that. Then you can weigh all the treatment considerations and determine which one sits best with you.
Mm-hmm. Yeah.
Yeah, I wasn't happy with the early course of my treatment, and I started locally. I live in the Poconos area, and then I went up to Sloan, and then I went down to Johns Hopkins, and I'm glad that I did, because when I went to Johns Hopkins, they decided that my Gleason had been read improperly and that I wasn't getting the proper treatment, and that my cancer was a little more aggressive than the others thought, and I definitely needed a change in treatment. And if I hadn't gotten that opinion, who knows what would have happened. You have to be your own advocate. You must be. You have to read as much as you can, and just don't take anybody's word for anything, whether it's a doctor or not. If you smell something's wrong, you better look into it and pursue it.
Well said. Well said. Thank you, Tom. Eric?
Yes. When I first was diagnosed, I went to UC and to Stanford to get, quote, other opinions. And Stanford was the least helpful. They just sort of had a mill that they ran you through. Oh, next. But you know, on that initial treatment, I was trying to decide radiation or surgery, and nobody was helpful with that. They all said, "Well, you could do either one." So, but since then, you know, getting in contact with the people at UCSF that are doing the trials, I went to see. I don't think I've talked to you since I saw Agarwal, have I?
No, you haven't.
He.
Hold on a minute.
He had no idea.
Let's stay on this one, and then I'll come back to you on your own stuff.
Okay. Well, I just meant that he's in charge of the trials at UCSF.
Right.
So he's very knowledgeable, and you know, when I went back to him later after I had metastatic disease, he's been helpful.
Mm-hmm. Mm-hmm.
So that's all.
Jay, what's your thinking? Because you're casting around to find the right doctor, and you finding these people that are outside of your network.
I'm listening intently. And we can get to the story from yesterday, but I'm out just looking. Yes, I mean I haven't found anybody that comfortable with that's been in network at least, and I may have to just fight it and deal with the people I want to outside my network, and go with it. But I have not been satisfied with who I've seen so far, and it's getting very frustrating. So I'd say just keep looking until you find the one that you're comfortable with.
When is the open period for you to switch your insurance?
It was up through the middle of December.
Okay. Okay. Somebody just shared something with us. Who was that?
Jake.
Jake, did you just share something with us?
I turned my webcam on. I probably pushed the wrong button. I know I pushed the screen button, and I should probably. I'm not showing anything, but let me undo that.
There you go.
Is that better?
There we go. Okay, now we've got. Now that's wonderful. We see you, which we always like, and we.
What was showing? What was showing on my screen?
An email.
Oh.
Oh, it had your social security number, everything. Don't worry about it.
That's okay. Everybody already knows that anyway, so that's no problem. Sorry about that.
Oh, well, you know, I want to sort of circle back to Len's very first comment, which is that provided that you are comfortable with the quality of the information that you're getting, I don't see what's bad about getting more information. Maybe there's a financial issue and that it might cost you, but especially when you're running up against new ideas for treatment, which is what some of you on the call unfortunately are, and you can access some really bright minds, then I do think it's a good thing to do. And interestingly, Rob said to me that if he was going to go for another opinion, he probably would go to Chicago and go talk to Alicia Morgans, because he likes the way that she approaches things, because he's listened to her on these presentations. And you know, there are a number of good guys around the country, men and women. I mean, I probably would say that we've got 6 to 10 docs around the country that are truly preferred. I mean, I would feel comfortable going to any of them personally. And maybe they're working on something in their lab that isn't ready for prime time, or they've heard about something. You just don't know. So I'm hoping that we can get Rob to think about it whilst he still doesn't have any pain, but his tumor burden is increasing and the mets are growing in soft tissue, and it's just, like I say, it's a very strange. Oh, he has peritoneal carcinomas, which is very unusual in prostate cancer. I don't know much about it, but that's what's been done. So keep him in your thoughts. Okay, so Peter, anything else before we move on from you? Anything you'd like to say about docs in and out of your network?
No, that's about it. You know, mine is not so much second opinions. Mine's just, you know, these are my primary doctors. My oncologist is a prostate oncology specialist, and my surgeon and radiation people have been up at UCSF. And,
right.
You know, I just chose to keep it that way. I mean, I had the choice to change it around early on, but I wanted to keep it that way, because, and I noticed very quickly that they had different views. I mean, Dr. Chang had a very different view of ADT treatment prior and post radiation than Dr. Turner did. And I chose to go with Dr. Turner's recommendation rather than Dr. Chang's. And so you're going to get, you know, not only you get different opinions sometimes, and you've got to make some decisions of who to go with and what to do, and you don't always have a lot of backup for that, but you just have to go with your gut sometimes.
Have you run into any significant issues problems by splitting the doctors like that?
No, I haven't. They seem to all respect each other and work together. Unlike the horror stories I hear here on Maui, where if you choose to go to a different doctor, the urologist here will cut you loose and say, "Well, go with them. I just don't want to see you again." I mean, just weird ego trips and stuff. I don't get any of that. I get people who really want to work together and respect each other.
Good. Okay. All right, Eric, why don't you tell us about your meeting with Dr. Agarwal and where you stand right now?
Well, the MRI that I showed that the tumors had not grown since the previous MRI, which was about 2.5 months before.
Mm-hmm.
So, it's having some effect. It's at least stopping the growth of the tumors. So, radiation, and Dr. Agarwal, another one 3 weeks after that. And Dr. Agarwal wants me to have a CT scan and a bone scan. At that point, he came up just off the top of his head with 3 trials that I could start on right now. As I say, he recommended that I stay with what I'm doing because since it seems to be working. And he had he dismissed the comments that Dr. Dolezal had given me that I should go up.
Good.
Everything's, things are working for you right now. There's no reason to give up, and then there's more things to try anyway. Because I'm still relatively healthy. I did say that I was worried that if we waited until the current treatment fails, that I might be too sick to go on the trials.
Mm-hmm.
And that's why we want to keep a very close eye on it and do a scan after the next treatment. So it was a good visit. It was very open to discussing everything, and I came out, with a much more positive view than after talking to Dr. Dolezal.
Well, that's, I see that was back, I think, on the 18th of December that we spoke last, which is a month, just about a month ago, just under a month ago. And that's why we really wanted you to talk to Agarwal, and it seemed to do the trick. The other thing is that you only just started that seems to be coming. Well, no, it wasn't coming from me. You only had just started the carboplatin, which one did you start on? You started on the carboplatin and then you added the Jevtana, correct? So you only had just started the Jevtana, so it seems like that combination may be effective. How are you tolerating it?
I'm not having any particular bad side effects. I'm having this problem with low blood pressure, but it seems to be controlled now.
Good.
So that was the major problem. My blood pressure would drop down, and then I couldn't do anything but lie in bed.
Okay. What were the trials that you recommended? Did you get into that at all, or can you tell?
Only a little bit. There was one about one of the mutations that showed up in my genetic analysis, the P1K3, something like that.
Mm-hmm.
Anyway, he says that there's a trial that's addressing that right now.
Okay.
And he mentioned 2 other ones, but he didn't give me enough details that I could give you any more information.
Did you record him, or because I know you go on your own? So, did you record him so you could listen later, or?
No, I didn't.
Okay. Well, try. If there's any possibility that you can take somebody with you to take notes or record him or what have you, I'm sure he won't mind you recording him. Then, I think we'd all encourage you to do that.
Yeah, I should have taken notes, that's for sure.
Well, it's a lot to be taking notes and asking the questions and doing everything, and I know it's difficult to take Gail because you've got to push and so that makes it hard, but if there's anybody that can go with you, or if you need anybody to go with you, let us know and we'll see if we can, work within our network and find somebody. But or at least just record him on your phone so that you can listen later.
Right. Uh-oh, we lost your video.
Yeah, my connection here is not. I don't think it's great today. I'm in and out, but you'll get me back. Everybody's frozen on my video anyway, and it could be wonderful GoToMeeting.
It's mine too.
Yeah, okay.
Mine too, Rick.
I'll
drop off. You've all seen how pretty I am, so now you don't need to. Maybe I'm overloading the system.
No. Okay.
Let's see if that makes a difference. My computer is also humming, so it doesn't seem to like all these connections all these USB connections.
Okay.
So I'll drop off.
Let me throw it open for other people to talk to Eric. Anybody like to say anything to Eric about where he is? I'm sure there's a bunch of you that are delighted to hear his options compared to what we heard last month.
Go ahead, Len.
Yep. Yes. Very happy, as Rick said, to see you doing well, Eric. And I have to congratulate you on your courage after the rough time you had with the first round of chemo. I guess it was probably docetaxel, that you would elect to go with a combination chemo. You must have thought long and hard about that. And I'm also really glad to hear that you're not getting the bad reactions that you had the first time around. I'm also interested in knowing, you said that your low blood pressure is being managed now. How are they doing that? Because I don't know why, but since my cancer diagnosis about 3.5 years ago, my blood pressure is always very low, like 100/60. Sometimes the top number even goes below 100. And I have no idea what to do about that. I wouldn't care normally, but I have felt faint a few times. And I suspect it's because of the low blood pressure. So what have they done for you there?
Well, here's the theory is that I was on Decadron, a fairly heavy dose of Decadron for a while, and what one of the side effects is that the adrenal gland will stop working. It's like, I don't need to do anything. There's all this steroid out there. I don't need to produce any cortisol.
Right.
And the problem is when you stop taking the Decadron, it doesn't necessarily kick back in. So I have what's called Addison's disease, which is that the adrenal gland is not producing cortisol. So they're giving me the hydrocortisone. It's apparently close to cortisol. And they say that probably the adrenal gland will never come back. And then I'll have to take hydrocortisone cortisone rather than, from now on. So,
Okay.
and I started out with low blood pressure. So having this added to it, I mean, I had to look my blood pressure. Well, I went into the hospital on December 6th because my blood pressure was 71/43. And they kept it there until they got a decent blood pressure out of me.
So what is it now? Typically?
It jumps all over the place, but typically I'm around 110/80.
That's good.
I also have a problem with tachycardia. My resting pulse rate is about 115 to 120. And I was getting some medication for that for a while, but it was another steroid. So that when they wanted to adjust the steroids, they cut that one out. When I was taking it, it brought it down to about 85. So now I'm back around 120. I also take a medication specifically to raise the blood pressure. It's called Florinef, or fludrocortisone. So it's another steroid. So it's just a mass of mostly steroids that they're using to treat the symptoms.
And the combination of carboplatin and Jevtana, is that a reduced or low dose of each, or is it normal dose?
It's a normal dose. When I started out on the carboplatin, I was getting it every week. And when they started the Jevtana, which is only done every 3 weeks, they switched to carboplatin every 3 weeks. So I get the both of them once every 3 weeks. And they haven't said to me how long I'll keep going. So,
as long as it works.
Yeah.
Okay. Good luck.
Yeah, I mean, Eric, I think that's a really smart comment that you made to him, that you want to be healthy enough to participate, and the fact that he's monitoring you closely between the two of you should keep you in good shape. But at the same time, as you said, the fact that these two drugs, these two chemos together are keeping you in good shape is really good. Let me just ask you. I mean, from what I'm hearing you say, this problem of your low blood pressure is related or was related to a sluggish adrenal, and then removing you off of a steroid too quickly. Is that right? Eric?
Oh, yeah.
I'm sorry. Is that? Did you hear me? Was the problem?
No.
That was the problem. They took you off a steroid too quickly, huh?
Yes.
You know, I've seen that before. The fellow that Peter referred to earlier on, who visits Hawaii, they did that to him. They took him off whatever it was, the prednisone, I think. They stopped him cold turkey, and it took him probably 3 or 4 months to get right. And I just feel sometimes, I mean, just a heads up for everybody on the call and anybody that listens to this later, that if you're on steroids and they take you off steroids, just double check with your medical providers how you should titrate off the steroid. Titrate means gradually come off, whether you should stop immediately, whether you should stop over a period of a week, 2 weeks, 3 weeks. But always ask that question about coming off steroids, because I think a lot of the docs don't think about it. And they don't give you, not a lot, but I think there are docs that don't. And, I've just heard about it, and not just with the two of you. I've heard about other people, but I think about this situation with Dick some years ago. He finished up losing 30 pounds, which was a lot. He couldn't keep any weight on until the adrenal finally balanced itself again. So I just want to give everybody everybody a heads up on that. Anybody else want to talk to Eric?
Like Len said, this is Jake. I'm just glad to hear that you're doing better, Eric. I'm glad you listened to your regular doctor rather than that other guy, because you know, we all agreed that it was a little bit premature to give you that kind of advice, and so I'm happy as a pig and you know what to hear that you're doing better.
Thank you.
Thanks, Jake. Okay. Anybody else to talk to Eric? I want to welcome some new people to the call. So just before I do that, anybody else like to say anything to Eric?
Before you go on, Rick, is your screen unfrozen yet, or is?
No.
Huh. I turned my camera off 10 minutes ago, and I'm still seeing my face.
I know. I'm seeing it frozen as well. So
everybody is frozen, right? Peter and Len.
Frozen.
No, Len and I are fine. We're okay, and Tom Van Zandt is doing fine. Three of us are on, and we're moving. We're not frozen. That's because we're in Hawaii and Florida. It's not cold here.
Larry Fish has told me his isn't frozen either, but I don't know what
I'm frozen. You're frozen. I don't know, and I can't even get rid of it. I can't. I don't know. I don't know what to do. Well, all right. So let me just welcome. We've got one person on the telephone. Who is that joined us recently?
I guess it's me, Sylvester.
Hello,
Sylvester. I wish everybody a good year. Hello.
Thank you, sir.
Good to hear your voice.
And Larry Fish is on also.
And I know Larry Fish and Tom Van Zandt. So, Tom, right. Did you have anything you wanted to talk about today? Tom?
Oh, you're talking to me?
I'm talking to you. Yes. Anything you'd like to speak about?
Yeah, I don't know how busy you are. I was just digging through old records and trying to find out just how sick I am, and I found some interesting things. Okay. I found out I'm a Gleason 9. It's a 4+5.
Okay. Well, we can come back to you. Larry, anything for you? Larry Fish.
Yeah, unmuting. Actually, I guess I'm all right. I guess, I don't know. We'll see what if Len wants to say anything or about our group, the group meeting we had that I may have missed. I just got in.
Yeah.
I didn't have anything. I had scans today and all day long. Okay. Bone scan and CAT scan, which they do instead. They don't like to do PET scans at Sloan so much, but nothing special to talk about yet.
Okay, well, Len wants some time, so we'll give you, the two of you, the time together to talk about your effort. So let me go to Jay Krupman. Jay, tell us about what's going on today.
Okay, I think the last time updated the group was back actually from a PSA back in November, where I was at 0.66. This is after prostatectomy and radiation and 1 round of hormone treatments, or 7 months of hormone treatments. I actually had an appointment with my urologist. That was my first appointment with my oncologist. Then in December, I actually had an appointment for something else with my urologist, and I just asked him if he'd do a PSA, and he said he would. So my PSA went from a 0.66 to a 0.83 in about 4 weeks. And yesterday I had a meeting, second appointment with my oncologist, and had a new PSA done late last week, and that came back at a 1.2. Mm-hmm. So it is definitely on the rise. And trying to figure out what to do next. The interesting point with my oncologist was he started out with Well, it's still 1.2, which is well below 4, so we'll see in 6 months.
Oh, Jesus.
And looked at him, he said, how about 4 months?
Oh,
And,
my God.
Looking at him, and so I knew I was in trouble at that point in time, or feel like I am.
Oh.
So he got it down to 6 weeks, but he goes, what do you want to do? I can, we can start treatment anytime you want. You want a shot of Lupron today? And I'm like, no, I don't think so. I'll regroup here and probably move on. But I didn't tell him that. I made an appointment, and we'll see what happens. But I am back in the hunt for finding somebody I think I can trust or work with or anything else. And it may be back to Dr. Morgan's up in Chicago, and I can reach out to her and her nurse and see if they'll take me remotely and work with my urologist in regards to treatments or things of that nature. But trying to sort through. I feel like I'm doctoring myself and treating myself. And I know you need to be your own advocate, but I feel a little lost at this point in time.
Yeah, not your own physician. Have you communicated with Dr. Morgans about the fact that Dr. Jackson was not, Dr. Walker in Jackson, Tennessee, was not in your network?
I did, and talking back and forth with them, and I need to do it, going through the enrollment again and everything else. I just haven't gotten there with the holidays, but need to send her a list of doctors in my network, and then she will see if she recognizes and or can vet any of them for me.
That'd be great.
So, yeah.
That would be ideal. And I mean, if you can find somebody that she can work with and somebody who's in your network locally and she can work with, and you can just pay her for her time. I mean, she sounds like such a neat person and compassionate and willing to help that, I think it'd be great if you could somehow or other keep her on your medical team.
Yes. And I think she actually comes off better in person meeting her than she does in her little films or little one-on-one she has.
Well, do you tell her we keep sending her business? Tell her we're very sad. We're very sad that we have to do it, but we do keep sending her business.
Do that. But I think I'm kind of with Dennis right now a little bit. Just I'm going up, and it's into a whole number now, which is kind of
right.
A point where I really didn't want to get to, obviously, but from here, doubling time of 6, 7, 8 weeks or something like that's going to start adding up pretty darn quick. So,
what kind of scans have you had?
I had a bone scan probably 6 weeks ago or so, and that was clear. That's back when my PSA was 0.52. I had one done at that point in time. So that was actually back 1st of November. So it's been a couple months.
What kind of insurance do you have? Are you on Medicare or do you have something else?
No, I'm on the Obamacare healthcare gov. Turns into a Cigna Connect program.
Yeah, well, and you're in a similar situation to me, but you're jumping it even faster. I would try to get a good scan. As I said earlier, I'm getting an Oxyman scan probably next month. And I want to find out what's going on. And you're certainly at a level where it would pick up something if you've got something. To find out where it's showing, because something's probably on the move, and you want to be able to get a good clear picture of it and be able to treat it if possible. So I would definitely talk to a doctor about that, about seeing if he can get a scan ordered, a high-tech scan of some kind, and preferably one that your insurance will pay for.
Right. That's where my oncologist I've met with yesterday just didn't provide any help or leadership or advice at all. So I got to find somebody else that understands this a little bit.
And you live where?
Memphis.
So, Jay, I think that's great advice from Peter, and I think that in your situation, just keeping it as simple as you can, that an Axumin, that's spelled AXUMIN, I'll put it in the chat window, that an Axumin scan is probably the way to go, because it is covered by most of the insurance companies now. And if it isn't, you can call Axumin. I forget, it isn't Axumin. What's their name? Isn't it Blue something or the other? What are they called, Peter? The owners?
Oh, yeah. I'll find it. I've got it listed.
Right.
Blue something. I can't remember what it is.
Right. But
Flucyclovine.
Say it again.
Flucyclovine.
No.
Isn't it?
No, sorry, Dennis. We're talking about the company that provides Axumin.
Oh, okay. Well, that's what they inject in you when they do the accident. Yeah, I thought that's what you want.
Blue Earth. Blue Earth.
Blue Earth. That's it. I'll put it in there. But if you talk to them, then they've got financial counselors there that will help you work with your insurance company. But in a situation like yours where it is increasing and you're trying to figure out exactly where it is, the scans that are available to you, Axumin is the easiest one to access. I mean, there are others that are slightly better, like the gallium-68, or there's another one that's even better than that. But I don't know that you're going to find them in Memphis. You might find them. You might find a better scan with Northwestern, but then you've got the issues of being in and out of network. But I'm pretty sure that you should be able to get I shouldn't say I'm pretty sure, but I think there's a good chance that if they won't approve it, that you can appeal and get it approved, the Axumin scan, because it seems to be becoming widely accepted. And people like Blue Earth, I mean, the manufacturers, and in other situations too, will do everything they can because it helps them. So that would be my thought. That's really good advice, Peter.
Yeah, I put their phone number in the chat room.
Thank you.
Great, thank you.
So I guess that you've got two things on your agenda: is getting a really good scan, getting a really good doctor, and then the issue is, what sort of hormone treatment? Because as I recall, you didn't respond too well to the Lupron shot, correct?
Well, the PSA responded very well to it. I just did not have, I had some pretty good side effects from it. So.
Well, we can help you. I mean, we can't control the side effects, but we can help you with suggestions how to mitigate them if you do decide to go on, because most everybody on this call in some way, shape, or form has wrestled with those side effects.
Right. No, I'll be much more prepared this time for it than I was last time. I just, kind of caught me. And
well, don't let it get too far out of hand. Try and get on the stick here as best as you can.
Yes, I'm doing that currently.
Okay, good. Okay. Tom Van Zandt, talk to us about what you discovered about your disease.
Oh, yeah, I've been kind of ignoring it for a long time, but I was trying to read up on how many lymph nodes are involved, and I don't really understand it, but the report says lower chest, 3 millimeter right lower lobe lung nodule. I think that's something that they just saw, but it turned out to be nothing. Everything else is okay, but then they get to the abdominopelvic cavity and multiple enlarged left pelvic sidewall and iliac chain lymph nodes. and they go into the size of the lymph nodes. And then left para-aortic lymph node, aortal caval lymph node, another aortal caval lymph node, and another one. So I guess it's quite a few lymph nodes. And then it says pelvic and retroperitoneal lymphadenopathy suspicious for prostate cancer spread. So,
and when was
what's that?
When was this?
I didn't understand. What?
When was the scan?
This was February 27th of 2013.
And have you been scanned since then?
Yes, I have, and things have been more or less under control, so I'm sure they see the same things, but the size of them has gone down somewhat.
Well, I'm not the real expert on where all these lymph nodes are. The person that was, God rest his soul, was Dominic. He knew all those lymph nodes. But Len, and you have lymphatic involvement. Throw some light on some of this lymph node lingo for us.
Yeah, it sounds like most of them are considered regional as opposed to distant lymph node involvement. The iliac chain, that's where my lymph nodes are involved. Is my voice echoing?
Yes.
Yes, it is.
So I got to reduce my volume, huh? All right, hopefully that's a little better.
It is.
Okay. I think the iliac chain is probably the most common spread for lymph nodes, and that can be hit with full pelvic girdle radiation, which, if I recall correctly, you were considering whether or not to do that. Is that right, Tom?
What happened is early on, back in like 2013 or 14, I got this diagnosis, and then I went up to Sloan and took all my slides and history up there from the test, and they looked at it and they considered radiation, and the doctor that I was with actually called and spoke to the radiologist, and they gave me the impression it was like a borderline case, but for whatever reason, they felt it would be too much radiation to do it.
At Sloan.
Yes, at Sloan. Yeah.
Interesting. Because I had my radiation done there, and Sloan is known for giving the maximum radiation dose, which is what I got, 86 gray for the full pelvic girdle. And I don't even think anyone else does that, so I'm surprised they told you that it's too much radiation when they're the guys who give more than anybody else.
What year did you get that?
2015, September 2015.
So, I mean, your situation and Len's situation, the two of your situations are pretty similar, I think.
Yeah, I'm also a Gleason 9. I had very dense cancer in the prostate, 75 to 90%, both lobes.
And we spent a long time convincing Len to consider radiation, and I think, I don't want to put words into your mouth, but well, I'll ask you, are you grateful you did your radiation?
Yes, sir, I am. Very grateful.
Yeah.
I can tell you right now, I've been on drug holiday from hormone therapy for about 10 months, and my PSA hasn't gone up much, whereas prior to radiation, I was also on drug holiday, and my PSA would race up rapidly, like from 0.2 to over 10 in 6 or 7 months. So it made a big difference for me.
I know I don't dare go off Lupron, or my PSA will immediately go up and go up fast. I know that.
Well,
yeah.
Maybe if you opened up this conversation again about pelvic girdle radiation and possibly debulking, it might not.
Yeah, I'm going to try and, like you said, get more information and take information with me and throw it all on the table on my next visit.
You know, I mean, there is reason to think that pelvic girdle radiation, even if you didn't debulk, which is a little different, but even if you didn't debulk, to do some pelvic girdle radiation might make sense, especially since you don't have any evidence of disease outside of the lymph system. Len, what sort of side effects did you encounter with the radiation? What would you tell Tom to watch out for?
Short term, I had almost no side effects. Longer term, going out now, I think probably like 15 months, 15, 16 months. I do see some blood in my stool occasionally, and if I see it too often, I'll use steroid suppositories, and that seems to keep things under control. However, I think Peter had some fatigue after radiation, but I never had any fatigue. You know, like everything, everyone reacts differently. So other bowel side effects that I've had is prior to radiation, I'd have like 1 bowel movement a day. Now I probably have 3 a day, but they're very small. I think it's common that guys will get some narrowing of the colonic tract, and I suppose that's why the bowel movements are smaller. So other than that and occasional little bit of blood, you know, we're not talking about a lot, mostly like spotting. Other than that, no side effects. So very tolerable.
Yeah, that's another thing I wanted to ask. You sent me an email, Rick, and it said something about, I've read up a little at times about they'll rate your disease as this and that, M1 or M2. How do I find out what I'm rated at?
So you would be rated, I think, as N as in Nancy, N1. Isn't that correct, Len?
Yes, N1 indicates lymphatic involvement.
Okay.
And M0 would be no detectable bone mets. M1 would be detectable bone mets.
Okay.
Right. So you would be.
There might be a further refinement of that, like M1A, M1B, but I can't recall the difference.
Yeah, I'm just looking it up just to remind myself, but I think that's right, Len.
But Tom, you should find all of that information in your pathology report.
Yeah, I don't see it. I have it right here, and I don't see it.
Well, just ask your oncologist.
Yeah, check with Gennesman, but you would be N1, which is yeah. I'm pretty certain in telling you that.
Yeah, you'd be T4N1.
Yeah. Correct.
And it says on here, paraneural invasion is present, whatever that means.
Right. Well, that means that it's gotten into the nerve tracts, and it's pretty controversial as to whether that makes a difference or it doesn't. Many of us on the call had paraneural invasion, and it's probably more of an indicator how you should attack the disease to begin with than what that means right now. And the fact that you've done what you've done would have, addressed the paraneural invasion to some extent. But paraneural invasion means it's gotten into the nerve channels.
Okay.
You may also have seminal vesicle invasion, as I did.
All right.
But, more to the point right now is how to address it. And,
right.
and if some radiation can help you, as it has Len, and allow you to take a much longer drug holiday, you're going to be a much happier camper.
Yes. Yeah. Right now, they just have me on the track of, your pay at PSA is staying down. So, take your Lupron, take your Zytiga, and don't bother us. That's the course of treatment I'm on right now.
Right. But
and whenever I ask about radiation, they say, "Oh, don't worry your pretty little head about that."
Yeah, but I mean, but you can tell them I don't want to be on. I'd rather not be on hormone therapy, and at least for periods of time. And they're going to say, well, you're always going to have to be on hormone therapy. And you're going to say, yeah, but maybe I can take a holiday, right? Isn't that right, Len?
Yes, and by the way, Rick, you had pointed out to me that study that was published or discussed in the new prostate cancer info link about, well, most of it was about post-prostatectomy salvage radiation therapy and how beneficial it was for guys with high-risk prostate cancer like you and me, Tom. But they also briefly mentioned that radiation showed benefit to survival benefit to people who didn't have a prostatectomy. So in other words, if they had radiation rather than just hormone therapy. Maybe if you have Rick, if you have Tom's email, you could probably send him that link that you sent me, or I'll send it back to you, Rick, and you can forward it on to Tom.
Yeah,
so you can read that.
I think
I remember that.
I think I've got it, but send it on to me, or I'll. You know what? I'm just going to I'll send you Tom's email address right now.
Yeah. Okay.
Okay, I'm going to send you Tom's email address, but. This is the sort of stuff, Tom, when we send it to you, you got to put it in the folder, and then you got to pull it out when you go see Gainesman and say,
Yeah,
absolutely.
And be sure to tell Len, when you send it, tell Tom which portion, because a lot of it's going to be related to people that have had a RP, and we know that he hasn't had an RP, but it also deals with people that haven't had an RP as well.
Right.
Right.
Okay.
The big thing I'm dealing with right now is a side effect of ADT is, I guess it's a side effect of that, is extreme fatigue.
Definitely ADT, yeah.
I'm getting real tired of that. Yeah. Well, I don't mean to be funny, but I'm getting sick of it. I really am. I can hardly do anything. You start to do something and then you're worn out.
Right. Well,
I don't feel sick,
Well, maybe, again, how much are you exercising, Tom?
I do exercise. I walk a mile a day. I wasn't doing it during this extreme cold we had,
sure.
But I have weight sets down the basement and different exercise things.
Well, you know, keep up that exercise routine, extend it. I mean, if you've got do you have an exercise bike at home?
I have a Gazelle. Yeah.
Well, if you've got an exercise bike, you know, get on that exercise bike if you can't get outside in the extreme cold, and you know, put on a football game or something and pedal. But it's really important to keep doing that. It's going to help you. It's not going to get rid of the fatigue, but it's going to help you. You've heard enough guys on this call tell you that. But I think the best possible thing is, I mean, again, not giving you medical advice, but I'm just talking on the basis of what somebody like Len did. You know, they were able to do, they were able to do the radiation, and then as a result of that, they were able to take a holiday and felt so much better.
Tom, what's your PSA been under ADT?
It's less than 0.
Less than 0.01, so it's been undetectable.
Okay. And how long have you been on ADT?
Probably a year and a half.
Okay. Well, I mean, the one thing you'd be thankful for is that you're still responding to it.
Oh yes.
Yeah, I mean, that's so it's doing its job, but I know it's a drag. It's you know, that's my biggest fear is going back on it.
You know, the other
Casodex wasn't working.
You know, the other thing is that maybe take a break on the Zytiga. But if you're going to do that, make sure you come off the prednisone slowly.
Yeah, but I'm almost certain if I take a break on the Zytiga, my PSA will shoot up.
Well, you don't know.
No.
You know, you can play around with that, but I do think you've got to dig more into this radiation. I'm going to. Anybody else want to talk to Tom? Because if not, I would like to get Larry and Len involved on this discussion on this new project, but I don't want to cut the discussion on Tom short if there's anybody else that would like to say anything.
One question, Tom. When you started Zytiga because the Lupron by itself wasn't working?
That's right.
Okay.
Yeah, I started with just Lupron, and then that didn't work. And Lupron, it controlled it somewhat, but my PSA would go up and down. And then they added Casodex, and that worked for, I don't know, maybe 6-8 months. And then the PSA started bouncing up and down again. And then I went on Zytiga.
Tom, did they withdraw catheter before they switched you to Zytiga? Did they try withdrawing Casodex for a while and see what that did?
Yeah. My PSA just went up. In fact, they withdrew the Casodex to get my PSA to go up so I could get Prevenge. And it went up immediately when I went off the Casodex. And I got the Prevenge and went back on it, and it wasn't controlling the PSA at all.
I suspect it's definitely had an effect, though, because it's actually pretty remarkable that with your pathology that your PSA is currently as low as it is. And as you said, I think you said Zytiga has been working 4 years, did you say?
No, it's about a year and a half.
Oh, okay.
But that, yeah, Zytiga has been working like a charm as far as PSA is concerned.
When are you seeing Gainesman again?
I see him in about 2 months. I see him every 3 months.
Well, you know, you could accelerate that too. Tell him you want to come down and have a chat with him. That, you know, you want to head down to Fox Chase and have a chat with him.
Yeah, it's not a bad idea.
I mean, why wait for another 2 months? You're not happy. You know, we can hear you're not happy. There are some options that are there. And, you know, for me, I'd want to address them. As you say, you know, you're your best advocate.
Maybe I should say something to him like, I'd like to move the appointment up as soon as possible and get the whole team involved to address possible radiation.
Any suggestions as to how to address this with your doc from anybody else?
Well, if I were you, I'll tell you what I did. My oncologist at Sloan was kind of like yours, and he said, nope, radiation won't be appropriate for you. So I just went and saw a radiation oncologist at Sloan, and actually I saw two of them, and they both said, well, you're definitely a candidate for radiation therapy. It would definitely help you. So then when I went back to my medical oncologist at Sloan, apparently they had a talking to him, and all of a sudden his tune changed, and then he started recommending it for me.
Oh, that's interesting. So you independently made an appointment with the radiation oncologist at Sloan.
That's right.
All right, well, that's good advice there on how to attack this thing.
Yeah.
And you know what? If you want, if you were interested in Sloan, for example, we could refer you to Boris. You liked Boris, didn't you, Len?
Boris is a fantastic guy. Yeah, Boris Mueller, Mueller. Very nice guy. He spent an hour with me going over my scans and showing me where the cancer was and which lymph nodes, and you know how he was going to approach it. Just a real nice guy, a smart guy.
Isn't he busy investigating the president right now?
Could be a relative, I don't know.
Maybe he should radiate the president. Maybe he should radiate the president's brain a little bit. That might help. So, oh, sorry, Jake.
I think Jake just dropped off the call.
Okay. All right.
That's all right. Everybody's entitled to their opinion.
Thank you, Jake.
Even if you're wrong.
Okay. All right. Well, look, Tom, we've given you a bunch of stuff to work with, and you'll get an email from Len. I've given Len your email address, and then you guys can even talk a little more and maybe figure out a way to strategize. But I do remember how Len came about this, and I think in retrospect, Len felt that it was a very good decision. Okay.
Well, of course, first Rick and Dominic pressured me to go talk to a radiation oncologist.
Right.
So we got to credit them first.
How many years ago is that you did that?
You know, before I said 2015, it was actually September of 2016 that I finished it. I started in, I guess it was July of 2016.
Right.
All right, well, thanks for the attention, fellas.
Pleasure.
Okay, good luck.
Len and Larry, talk a little bit about.
Okay, I'll just kind of introduce it, and I'll turn it over to Larry. So it was Larry's idea that we meaning members of this AnCan organization, have a project where we provide a service by investigating clinical trials and then reporting to the group and even posting our results on the AnCan website. And of course, it's one thing to say that and another to do it, because there are literally many hundreds of clinical trials for prostate cancer. So, you know, I think it was just yesterday, Professor Bill Burns and myself and Larry had about an hour session on GoToMeeting, where we tried to create a more manageable sized project. And Larry, I'll let you take it from there.
Well, thank you, Len. You know, it was just it just was an idea that I had. It wasn't, and the way that I originally got the idea was speaking to my med-onc, to Karen Audio at Sloan. And we've been looking for a while at some potential trials for me. And I was asking her if, you know, maybe it would be useful for me to look myself at clinicaltrials.org, or as we now are doing NCI.clinicaltrials. And she said absolutely it would be, because there's no way that she could ever or would ever think about like looking and searching through the hundreds and hundreds of potential trials that might be applicable. So I brought it up to the group, and I thought, well, if we've got like 5, 6 people, or 3, 4, whatever number, and we would commit a small amount of time each week, we could just divide up the searching process and take a look and see what clinical trials might be appropriate for our stage 3, 4 metastatic advanced group, non-metastatic, metastatic, for advanced prostate cancer group specifically. And so we, as Len said, we talked yesterday about some of the complexities of looking at this by, you know, by what kind of how would we categorize the trials? How do we search? And we're sort of restricted more or less at this point to the United States, to active trials, to phase 2, phase 3 trials, more than phase 1, as Lynn pointed out. 90% plus of phase 1 don't go anywhere, and there may be very interesting and great ones there, but it would be endless looking at things and spending time for maybe no purpose. So we're going to try to, my concept of what we decided is try to come up with something, you know, efficacious in some way that are really open and active trials that are currently active, things that people could look at for their own benefit. And while we would be looking for things that would pertain to us, it would also be looking generically at advanced prostate cancer trials, and which are ongoing. We would sort of sift through the existing trials and try to find the ones that seem most pertinent and most relevant and maybe of interest. And then we would review those ones that we've each independently looked at, and maybe come up with some to suggest to Rick that we present at the group meeting. Right now we're in the process of just listing each of us taking a look at the cancer clinicaltrials.org or NCI.org, or even pharmaceutical trials, and just developing like a list of what we think are the kind of categories that we would use. Would it be, you know, personalized medicine? Or would someone look at new hormone therapies? Would someone be looking at immunotherapies? Would someone be looking at bacterial adjuncts, at these combo? So we're just right now at that stage of and then we'll develop some protocol for how we're going to track these, and we'll have the website, the abstract, and maybe some notes, and then how we're going to track them, what's the protocol that we'll use, and hopefully we're going to dive in pretty soon. That's how I see it, Len. I don't know. You want to add?
Excellent summary, Larry. I agree. We did, Larry and Bill and I agreed that we would independently determine how to categorize the trials and how many trials we're talking about in these categories of phase 2, phase 3 actively recruiting. And we'll have another, we'll share our results this Saturday. I'm sorry, Larry, you know, I don't even remember. Did we just agree that we would share them via email, or are we actually going to have another GoToMeeting session on Saturday?
Well, Actually, I thought what you would do is you would share your categories with me and Bill would then share his categories with you and me, and then Saturday I would share my categories back, and then we would. No, I'm just kidding. And then we would get together at, I think it was 11 o'clock on Saturday, back in the meeting room.
Right. So it's a big project. It's not going to happen quickly, but we decided we'd scope it out that way. We'd let Rick know what our plan of attack is and see if he's on board with the whole thing.
And then
his input.
Right, and then try to put together the group of people who would be with us.
Right. So George Silverio and Jeff Ledoux expressed interest in helping. And if anybody else has an interest in helping, then of course you're very welcome, and you can either reach out to Len or Larry directly, or to me, and I'll pass it on. And one really nice idea that I saw thrown around in this discussion was that the people would look at what particularly interests them or they think might help them the most. So, you know, what Len might look at might be something different to what Larry might be interested in. So I think there's a sensitivity to try and tailor this research to what is most interesting and most useful to the researcher themselves. Is that correct, Jen?
Yes.
Yeah, I saw it as the first thing. We would start from where we are, the stuff that's interesting to us, and also we would try to do a little bit more generically according to whatever categories we were, most interested in looking at, even if it may not apply directly, to try to broaden it, but to start from where we are and to put some time into broadening it for things that might be applicable to the whole group.
Great. And Peter, as you know, and we've discussed, we're very, very happy to extend this to low and intermediate prostate cancer trials. If there are men that you might want to recruit that would be interested in looking at, say, active surveillance trials or something that's more related to lesser cancers. But I mean, it's your call, but it would be nice to try and include that as well.
Right. Yeah, I have to look at my time commitment and see if I can get on board with that or not, or if I find someone else who's interested in that kind of research.
Right. I mean, we're not asking you to do it personally, because I know that you have a pretty heavy load, but what we're asking is if you would extend that message to people that you and Ken have on your distribution. Ken might be a person that might be interested in doing some stuff.
Right.
But, just to let people know that this is what we're doing. And if somebody wants to get into the active surveillance trials, then that would be dynamite.
Yes. Yeah, it's an excellent idea. Because I know when you just go in as an individual and start searching for clinical trials, it's overwhelming. I agree. If there's any way to kind of sift through some of this stuff, I've tried to look at things a couple of times and given up pretty quickly because it was just too much information.
Right. Well, who your active participants are in the low and intermediate call, and so maybe you can talk to them and see if there's any interest, and if so, then probably it would be good to let Larry and Len know, because the categories they're focusing in on right now are tending to be more related to recurrent and advanced disease. And, they may want to include a couple of categories that are for lesser disease, like, for example, active surveillance trials.
Right.
Okay. Well, thank you, gents. I mean, I honestly cannot thank you enough. I mean, Larry, it was a terrific idea, absolutely terrific. And I think that when we get it up and running, it's going to help a lot of people. And as you well know, that's what we're about. And the more people we can reach out to and extend and help, then the better I sleep every night. So, thank you. Okay.
Sorry if you can't. Yeah, thank you, Rick. I'm glad that I'm glad it's of interest. I mean, we won't really know until we won't really know until we start trying to actually sift through and see what it's like to whittle this down. It's just a thought at this point, and we're going to try to get our feet wet as soon as possible, I hope.
Right. And it'll go through some iterations, and it's I mean, one of the toughest things is going to be how we present it. That's going to be one of the hardest things, because we have to present it in a way that's easily understandable to people that are not familiar with reading this type of information, and that's always a challenge. So, but we'll get there, and it'll, take some time, and, I'm hoping we can have something up and running by the end of this first quarter, but, if it takes longer, it takes longer, but I'm just thrilled that we're addressing this. I think it's terrific. And probably once we get it up and running and publicize it, then the others will copy us, just like has happened in the past. We'll see. All right, gents. It's 6 o'clock my time. It's 8 o'clock back east. And I have no idea what time it is in Hawaii. It's probably 4 o'clock. Is it 4 o'clock in Maui, Peter?
3 o'clock.
3 o'clock in Maui. I can never quite get it right. Okay. So, all being well, I will speak to you Monday, I think. Yes. Today's Tuesday the 9th. So the next call should be Monday the 15th. Oh my gosh, I just saw that we have 5 Mondays in January.
Yes.
Okay. Well, I will see. There's a good chance that we can still have a plenary, and if so, it will probably be on sleep issues. And I will let you, if that's going to be the case, then we'll probably know by 10:30 tomorrow, because my buddy who's driving me up to Tucson tomorrow is the person who would give the plenary. He's a professor at the Arizona Integrative Medical Institute. He works very closely with Andy Weil and has done for years. So, and Dennis has heard a version of this presentation, and I think it would go down well, don't you, Dennis?
Yeah, I think it could be a little tuned up a little bit for our group.
Yeah.
But it was kind of, maybe more directed at a physician's group or something like that, I think.
Yeah.
The initial version that I heard, yeah.
I agree. No, I mean, I'll try and hone him in a little bit, but I didn't realize it was. Well, I mean, we have enough time, so we have enough time. So if he's available on Monday the 29th, then we'll look at that. All right, guys. Take care of yourselves, everybody, and we'll talk to you next week.
Okay.
Thank you, Rick.
Okay, wish you well.
Good night, everybody.
Thank you.
Good night.
Thanks.
Bye.
Bye.
Good luck with your surgery, Rick.
Thank you. Thanks. Bye.